Professor Linda Clare is a professor of clinical psychology of aging and dementia at the University of Exeter. I first met Professor Clare at the University of Bangor in Wales when I was external examiner. Professor Clare is a trained clinical psychologist, and she currently leads the University of Exeter's Centre for Research in Aging and Cognitive Health, acronym REACH. Professor Clare's research aims to improve the lives of older people and people who have dementia through a focus of maintaining cognitive health in later life. But critically, the focus of the work in her program is living well with dementia, as well as developing rehabilitative approaches to optimizing independence and well-being and supporting family care. This includes the IDEAL longitudinal cohort study, which we heard a little bit about previously from Dr. Wu's presentation. The IDEAL longitudinal cohort is a collaborative project based in the UK that includes samples from across the United Kingdom, Wales, England, and so forth. The work of Professor Clare not only includes the IDEAL longitudinal cohort study, but represents the Alzheimer's Society Centre of Excellence, which investigates the factors that help people with dementia and family carers to live well with this condition. Professor Clare has published over 250 peer-reviewed journal articles and book chapters. Professor Clare is a fellow of the British Psychological Society, the Academy of Social Sciences, and the Gerontological Society of America. She is a National Institute of Health Research senior investigator, and she serves on the governing board of the Global Council on Brain Health. In 2004, Professor Clare received the May Davidson Award from the British Psychological Society for her contribution to the development of clinical psychology in the UK. Professor Clare was also awarded the degree of Doctor of Science, the highest degree from the University of Cambridge, one of the world's leading research institutes. In 2015, in recognition of her work on the awareness, increasing the awareness of people who live with dementia, and critically, their carers. So clearly, Professor Clare is an outstanding person in the field that we are focused on at this meeting, and we are absolutely delighted that she completes our series of speakers, nicely complementing the University of Cambridge that began with Professor Brain, and Professor Clare, as an honorary degree holder, Doctor of Science, is the ideal candidate to wind us up. So please go ahead, Teresa, and present Professor Clare's recorded lecture.
Hello, I'm Linda Clare from the University of Exeter, Professor of Clinical Psychology of Aging and Dementia in the University of Exeter Medical School. And thank you very much for inviting me to talk to you today about our research on living well with dementia. Living well with long-term conditions has been defined very helpfully by the Institute of Medicine as the best achievable state of health that encompasses all dimensions of physical, mental, and social well-being. It has a personal meaning which is unique, defined by a self-perceived level of comfort, function, and contentment with life. And the definition also emphasizes it is shaped by the physical, social, and cultural surroundings, and by the effects not only on the affected individual, but also on family members, friends, and caregivers. So here we see that multiple domains of life are important for living well, that context and relationships are vital, along with that personal feeling of satisfaction or contentment with life. And this definition acknowledges the need to encompass diverse aspects of well-being. We need to think beyond the illness itself and take a positive, holistic view. We need to take account of each person's social context, environment, and relationships, and acknowledge the unique elements of each person's experience. Now, while I'm talking to you about living well with dementia, I want to acknowledge there are differing views among people with dementia themselves about the appropriateness of the term living well. So although I will use this term, I am aware it may not sit right with everyone. So I ask that you think of it as representing a genuine aim to enable people with dementia and those who support them to achieve the best possible level of well-being. So why should we focus on living well for people affected by dementia? Well, dementia, of course, as you know, is a global challenge. We have nearly 10 million new cases every year. That's one person every 3 seconds. And there are 50 million people worldwide, with those numbers set to triple by 2050. And most of them in low and middle income countries. The cost to society and to individuals is huge, especially given that family and friends provide most of the care. And carers, of course, experience multiple demands and stresses. A person with dementia, just like anyone else, thinks and feels a lot about his or her life, and how each of us think about our life, how each of us feel about our life is important, and people with dementia are just as important as everyone else. But dementia poses particular challenges for living well for a number of reasons. Symptoms of dementia make things harder, and they can also have a wider impact, such as leading to anxiety or loss of confidence. Others don't always react positively, and our environments are not always well adapted for disability in general, and certainly not for older people and people with dementia. Communities are not always inclusive, or as inclusive as they could be, and all of these challenges affect how well a person is able to function, and they result in limitations on activity and participation, which make life more difficult. So, are we doing enough about promoting living well for people with dementia? Well, from the UK angle, I think the general consensus is that we are not, that there is a need to vastly improve our social care system. And from a research perspective, both in the UK and internationally, the amount we're doing to focus on living well with dementia is very small relative to other areas of focus. So this chart shows some work. This was an analysis done by our Alzheimer's Society that looked at international research funding. And this was in 2016, and found that the proportion of funding for dementia research that looked at care, support, and health economics, so also costs, is shown by this small blue area here. That's just over 3% of all funding is going to look at care and support. And some of that is looking at costs of care and services. So I think that's very clear that for the 50 million people worldwide living with dementia, this is a very small area of focus on living well, and we do need to do more. Now, when my group started to look into this in detail in maybe 2012, 2013, and we did begin with a large systematic review to understand what evidence we could find about living well with dementia. And this review covered international literature. It included information from over 30,000 people with dementia. And what we found was actually there's not a great deal to go on in terms of improving, where we start with improving capability to live well. There were a lot of individual factors with small relationships to quality of life, which is the only indicator we could really find examined in the literature. And very few of them with more than small effects. So we could see that, for example, good relationships, good social engagement, and better ability to manage everyday activities was associated with better quality of life, while poorer mental and physical health and poorer carer well-being were associated with poorer quality of life for people with dementia themselves. But there was no overall picture, no coherent way to understand how all of these different factors interact together. And most importantly, we looked for what could tell us about predictors of people of improvement or decline over time, and there was very, very little at all to go on. So we set out to achieve a number of things. We wanted to create a comprehensive picture of what enhances or hinders capability to live well with dementia. And we wanted to understand how capability to live well changes over time as dementia progresses. We wanted to know how to identify people at risk of decline in their ability to live well. We wanted to identify what contexts, conditions, resources, initiatives, and interventions are needed to support living well effectively. And we wanted to support personalized planning for living well. So from there, we went on to develop the IDEAL program. IDEAL stands for Improving the Experience of Dementia and Enhancing Active Life. And this had its origins in an initiative around the G8 Dementia Summit in London in 2013 to provide for social science research in dementia. So IDEAL is a social science research program on living well with dementia. It is now funded in its second wave as an Alzheimer's Society Centre of Excellence. And central to the program is involvement of people with dementia and carers in shaping the work. And we have an involvement group called the Always Group, some of whom are shown in the photograph here, who advise us from their perspective of living with dementia, either as a person with dementia or carer. Now, IDEAL does encompass both people with dementia and carers and does look at living well for both people with dementia and carers. However, in what I'm going to talk about today, I'm going to focus on people with dementia. Now, support for carers is vitally important, and they are absolutely crucial. Those family members and unpaid supporters who provide most of the care. So I don't want to detract from that, but what I'm going to focus on today is people with dementia themselves, and in particular, people with mild to moderate dementia who are living in the community. So just to introduce the structure of the IDEAL program, the first part, we were going to follow a large cohort of people with dementia and carers over for 12 months follow-up and well, 1 year follow-up and 2 year follow-up, so over that period. And we then had a 2 year gap and we moved to the next phase, again going to follow them up at 3 yearly intervals with detailed interviews in their own homes. The original first phase included some additional in-depth interviews with a smaller number to enrich our understanding, and an arts-based project called The Unfurlings, which I'll mention later. The second wave, the Alzheimer's Society Centre of Excellence, included again additional in-depth interviews, linked studies with seldom heard groups, and some drama-based work. However, at the point where we were just about 3/4 of the way through our fourth wave of data collection, the COVID pandemic began. And so in this phase, we have instead had some dementia, some COVID initiatives. Well, first a small initiative, and secondly our Include Rapid Response project, which I will also mention later. And right now we are just starting data collection for the final time point, time 6. How are we learning about living well from the IDEAL cohort? Well, we have measured living well with ratings of quality of life, well-being and satisfaction with life, in line with that definition by the Institute of Medicine. We've asked people what they think living well means to them, what's important to them, and we've had in-depth interviews about it with a small subset of participants. Now, in terms of what we're looking at as regards to possible influences on living well, we look at people's experience in several life domains. And these are physical health, physical fitness and health, psychological characteristics and health, social resources, social situation, and managing everyday life with dementia. So physical health, obviously including things like fitness, physical activity, other health conditions. Psychological health, covering things like depression, loneliness, optimism. Social resources, the kinds of social capitals and assets that people are able to draw on. and social situation, their perceived standing in the community, their living situation, and managing everyday life. So dealing with the impact of dementia-related symptoms, such as effects on cognition, on everyday functioning, and so on. We've also looked at how the person with dementia and carer influence each other, so the well-being of one could influence the other. And of course, we're interested in changes over time. So we're following people, as I said, for up to 6 time points at yearly intervals, with a 2-year gap in between time 3 and time 4. So what we have done is, first of all, look at individual possible influences on quality of life, well-being, and satisfaction with life within each of these domains. And then in each domain, we have taken those aspects which are important and significantly associated and modeled them together to see the effects of the domain as a whole. So we've done that within each domain, and then for all the domains, we have finally put them all into one statistical model to give us that overall picture of how all these different things are influencing ability to live well. So I'll just show you a couple of examples first of some of the individual aspects that we've looked at before I go on to how we group them together. So in the physical fitness and health domain, for example, here's some data about health conditions. So you can see that of our nearly 1,500 people with dementia, the majority had some other health conditions, usually 1 or 2, but sometimes more. And in this right-hand chart, you can see that the number of health conditions the person had is directly associated with quality of life. So the more health conditions, the poorer the rating of quality of life. A very clear association. Now, to take another example from the psychological domain, we looked at loneliness. So on the left, you can see the prevalence of loneliness in our, again, nearly 1,500 people with dementia. So fortunately, about 2/3 did not feel lonely, but we had 30% who felt moderately lonely and over 5% severely lonely. And again, now when we look at the association of loneliness and well-being scores, we can see that the degree of loneliness is associated with the well-being score. So people who are not lonely have better well-being scores than those who are moderately lonely, and in turn their scores are better than those who are severely lonely, who do particularly poorly on well-being. So these are some examples from the individual factors. As I said, within each domain, we first modeled the association of each domain with our living well outcomes, which was this composite of quality of life, satisfaction with life, and well-being. And in this chart, the orange bars show how the individual domains are linked to quality of life, well-being, and satisfaction with life. And these are effect sizes. So you can see that each domain is in fact significantly associated with living well. So all of the domains are important for living well, and you focus on those orange bars. But now if you focus on the blue bars, you'll see that psychological characteristics and health still has a strong effect, but the other domains much less so. And in fact, psychological characteristics and health is the only one that is significantly associated with living well when we model all the domains together. So we understand that to mean, or we interpret that to mean, that all of the domains are important and they have their effects on psychological health, psychological well-being, and that in turn is very closely linked to how people evaluate whether or not they're living well. So putting all of that together, we are developing, it's still emerging, a living well map based on this evidence. And we do have the equivalent one for carers, but as I said, I'm focusing on people with dementia here today. So in this map, you can see the 5 life domains that I've mentioned already, as well as the additional box which shows the effects from the care partner. So for example, so in each box, you can see some examples. Those in red are aspects that are supporting living well, and those in blue are the aspects that are undermining living well and making it harder. So here, for example, in social resources, we can see that engaging in social activities and feeling positive about the neighbourhood you live in are linked to better capability to live well, while being socially isolated is linked to poorer capability to live well. And so on. In the other boxes, the same convention. So for example, in psychological characteristics and health, feeling generally positive about yourself and feeling able to cope well are linked to better scores for living well, while feeling lonely, feeling I'm not the same person as I used to be, and being depressed are all linked to poorer scores for living well. This feeling not the same person is quite interesting. It seems to be a very good marker for poor scores on living well. If people are saying they have this sense of discontinuity in who they are. And then effects from the care partner. If the care partner is feeling competent as a carer, that seems to be linked to the person with dementia doing better. And equally, if the care partner is isolated and feels stressed or depressed, that has its own impact, or rather negative impact on the person with dementia. So again, support for carers is really vital. Okay, so this is really based on our cross-sectional evidence, if you like. Now, the other thing that we really want to know, and we really couldn't deduce from the original evidence, and we have, in a sense, met our aim of putting a comprehensive picture together, but what about changes over time? Now, I think many people would probably imagine that ability to live well, indicators like quality of life, naturally decline as dementia progresses, and that the experience that people report might be of a generally poor quality of life or satisfaction with life or well-being anyway. But actually we find that is not the case. So here on the left, you can see this is our 3 time points. And when we look at the whole group together, indeed, there is no change, hardly any change, let's say, for the whole group taken together over those 2 years. But we can divide that up, and we find people with different trajectories of living well. So the top line here represents the largest group, this pink group here, and they are stable over time in their ability to live well. And they also start off with quite good scores on living well. This is actually mapped onto the quality of life in Alzheimer's disease scale scoring system, although the measure includes also satisfaction with life and well-being. And so they're scoring quite well, and that stays the same. There's another group that are stable as well, this blue group, that accounts for about 12 to 13%. And they start off with very markedly lower scores, and they stay the same over time, this blue group here. And then we see two other trajectories. One, this group here in the orange, who start off reasonably well, but decline over time and come at the end of 2 years, they're at the level of the low stable group. And then this group here, the green group, who start off with poor quality of life and well-being scores and do improve over time. That's about 5% of the sample, this green group here. So this is very interesting because it allows us for the first time really to demonstrate conclusively that, that the overall finding that we see in the literature of little change over time is true when you take the group average, but that masks different trajectories, and that there are groups in reasonable numbers who have different trajectories. So so we can see that about 1 in 10 will decline, and about 1 in 20 will improve over time. So this starts to give us an idea of what we might be doing when we see people with dementia fairly soon after their diagnosis. We could start to tease out which of these groups are they likely to belong to, and tailor our support for them according to what we find. So with the stable group that are scoring quite well, we want to make sure they maintain that level. And we want to identify those at risk of decline and stop them declining if possible. For the low scoring group, we want to try to improve their scores. And for the improving group, obviously, we would love to capture what it is that they're doing and bring the rest of that low stable group up into an improving category. So combining our living well map And this understanding of how people progress over time will start to allow for a more personalized approach to supporting people and planning care. Rather in our own trajectory of research at this point, we were rather disrupted by the advent of the COVID-19 pandemic, which of course has had a major impact in the UK as in many other countries. And so this then immediately prompted us to ask how the pandemic might affect living well. And it occurred to us that it is actually a very good natural experiment to test our broad social model of living well. Because thinking about the domains of life that we explored and the individual factors within them, we could see many, many areas where the pandemic might have an effect. It might have an effect on people's ability to feel optimistic, positive, able to cope. It might increase loneliness, depression. It might reduce ability to engage in activity, might increase isolation, and so on. So, of course, it could also have a major impact on carers who might find themselves either worrying about a person with dementia who they weren't living with, or really trying to support someone 24 hours a day without any break whatsoever, as many other support services had to stop. So we decided to use the IDEAL program to try to investigate this, and we began from the point of wanting to help in some way. And given that we were all rather confused about the guidance and information available, this seemed to be much more the case of people with dementia and carers. And so we did begin by producing some evidence-based guidance. And we then went on to interview a small number of participants from our IDEAL cohort about their experiences during this first wave of the pandemic. And that was in May 2020, and followed some of them up in June 2020 when restrictions were starting to ease. We found out a great deal about the negative impacts and some of the things that helped. We're seeing negative impacts included isolation, loneliness, physical disconnection from loved ones, greater anxiety and depression, a feeling of declining skills and abilities, reduced access to services, and a lack of personalized advice. But of course, there was some support available from where support was available in the community. That was appropriate. This was very helpful. Alongside the personal resilience people were able to bring to the situation, and many commented on how they had to cope already with the challenges of getting a dementia diagnosis, and this had prepared them for coping with difficulty. Even though many services stopped, where services of support services were able to keep in touch just with short phone calls every now and then, that was perceived as very helpful. So having completed that study, we then moved on to a round of online data collection. So we now moved from individual interviews at home to calling people up on the phone. And we collected data from as many people with dementia and carers in the cohort as we could during the second wave of the pandemic between September 2020 and April 2021, when, again, restrictions were still in place in the UK. We had structured telephone interviews with 173 people with mild to moderate dementia and 288 carers of people with dementia. And that included 126 dyads, so where both members of that caregiving dyad took part. And we were able to look both at people's views and perceptions of their experience, but also at some indicators that we could benchmark against pre-COVID data. So we took data from the third wave of data collection in IDEAL, that was pre-COVID, the last complete data point, and were able to see where things had changed for people. So I'll show you first of all the perceived impact of the pandemic, and this shows responses from people with dementia, there's the blue bars, and from their carers acting as informants, the orange bars. So the informants are talking about a larger group of people with dementia, some of whom are not responding here. So there are two different groups. So if you look at the blue bars those are people with dementia, and the orange ones, as I said, are carers. So first of all, here on the left, this is about healthcare, and we see that people did feel their healthcare was affected, nearly half of the people with dementia, and over 2/3 of the carers. In some cases, health services they needed had stopped, and one in 5 of the people with dementia said they had avoided seeking help for health problems during the pandemic. A smaller number of carers thought that people with dementia had avoided seeking help. Then the next set of information is around perceptions of functioning. And this shows the proportion who thought that their functioning was worse, or that the person with dementia was functioning more poorly in a given area. So here we have everyday memory, memory for events, concentration, using language to say what you want, being able to plan ahead, being able to make decisions, and frequency of being confused. So people with dementia, again, somewhere between 1/3 and a half were experiencing decline in these areas, and for the carers it was typically more between 1/2 and 3/4 who perceived a decline in those areas in the person they supported. Interestingly, nearly half of our participants with dementia thought there were some positive benefits nevertheless, but only 1/5 of the carers. And despite all of these difficulties, our stoical group mostly thought they had coped well with the situation. 90% of people with dementia and 80% of carers thought that the person with dementia had coped well. So moving on then to think about how the perceptions of people with dementia looked against the benchmark of pre-COVID data. What I've done here is to summarize the areas where we found significant differences. Most of these, as I said, are benchmarked against ideal time 3. There are 1 or 2 which we compared to the English longitudinal study of aging COVID sub-study, which was conducted around the same time. So I will explain which ones those are. So first of all, some things that were seeming to work better. So people with dementia, compared to their pre-COVID responses in IDEAL, were more satisfied slightly with family support and more optimistic. They, to a small extent, there were more who expected more good things to happen than bad. That might have been, we could speculate, to do with the development of vaccines and the potential for things to improve during this second wave. Compared to the English longitudinal study of aging, there were fewer in our cohort who thought that they were financially less well off as a result of the pandemic. Not surprising, because the English longitudinal study of aging includes over 50s, many of whom still in work, who may have lost their jobs or been on furlough due to COVID. If we look at functional ability, these all compared to ideal time 3. Self-ratings of memory, a higher proportion thought their memory was poor or very poor. Higher proportion thought they had difficulty with self-care. A higher proportion felt they were not the same person as before, and a considerably higher proportion felt lonely. So 20% in time 3 and 40% nearly at in include. Then if we move on to what we could think of as indicators of capacity to live well, we can see the impact of the pandemic here. So significantly fewer were satisfied with their life. Significantly fewer felt the things they do were worthwhile and meaningful. And significantly fewer rated their life overall as good or excellent. Now I'll move on to the equivalent ratings made by carers as informants. So these are informing about the person they care for, which is a slightly different group to the one we just looked at. So compared to ideal time 3, interestingly, although they were still, so the blue bars include informants this time, and the orange bars are the benchmark data from ideal time 3. So there were fewer informants thought that the person with dementia was experiencing moderate or severe pain, although still a high number. And fewer thought the person with dementia was depressed or anxious, interestingly. Compared to the English longitudinal study of aging, there were a higher proportion worried about having enough food during the pandemic. There were a higher proportion who thought that the person with dementia was having difficulty looking after him or herself. A higher proportion perceived mobility problems, and a lower proportion thought that the quality of life of the person with dementia was good or excellent. So that mirrors the finding we saw for the people with dementia. So this was, a very good test of our model. So coming back to our emerging living well map and our understanding of the trajectories of living well, we now, of course, have an additional challenge in that circumstances have impacted on everyone's ability to live well with dementia. So we have more ground to make up. So what needs to happen to promote the capability to live well with dementia in the community? We can think about this from two directions. Firstly, if we focus on individuals and families, then a map that shows strengths and needs and identifies actions needed to maintain or improve well-being or prevent decline would be valuable. Then there is a need for people to be able to access support to develop strategies for making the most of their functioning and functioning as well as possible, and managing life with dementia as well as possible. And then, of course, there's also a need for targeted evidence-based interventions for specific problems such as depression or other difficult symptoms. And the evidence base for this was documented really well in the 2018 NICE guideline. And I think that really highlights the need for, again, better understanding of how to address some of these very specific problems. We have some indicators, but there's more work to do there. And secondly, if we focus on communities and wider society, then the need is for a social context that includes, accepts, and enables people living with dementia. And I'm just going to make a few more comments in each of those two areas, those two directions, more individual and more social. So in terms of individuals and families, and this is ideal data again, the ability to manage everyday activities is associated with capability to live well. So the better the ability to manage everyday activities, so this is the better ability, and this going down here to poorer ability, the better the ability to live well. So this in terms of quality of life, satisfaction with life, and well-being. So scores on all these measures go down as ability to manage everyday activities decreases. So in our own work, we have trialed an intervention that aims to enable people to better manage their everyday activities and maintain their confidence and independence. It's called Great Cognitive Rehabilitation. The graph I'm showing here is from a large randomized controlled trial, which included nearly 500 people with dementia. And they all identified areas that they would like to manage better in their daily life. And then half of them were randomized to have a support from a practitioner, and half of them just continued their treatment as usual. And we rated, and we got them and their carers to rate how they were doing in those areas they had picked initially, and after 3 months at the end of the support from the practitioner, and after 9 months. So this is the group that had the intervention, that had support from the practitioner. The blue bars are their baseline ratings, the orange, the ratings after 3 months, after they'd had 10 home visits from the practitioner, and the grey bars are what happened another 6 months later. So you can see they made gains and they maintained them. And the carers had pretty much the same picture in their ratings too, whereas the group that didn't have support from the practitioner did not change significantly. So we can enable better functioning in everyday life. That was a large randomized controlled trial done under very rigorous conditions. Can we take that out into everyday health and social care services? So we have been training staff in National Health Service teams and in private care provider teams to offer this enabling intervention, great cognitive rehabilitation in their services. Again, has been somewhat impacted by COVID, but we have been able to train staff in 12 teams. We've had 54 people with dementia who each had the intervention with an average of only 6 home visits this time from a practitioner. Almost unanimously, they found it useful and would recommend it to others, as did their family members. And what you can see here again, these are the ratings. So they chose the areas to work on. They rated how they were currently doing on a 1 to 10 scale, and then they rated again after they had the intervention. And people with dementia, family members and practitioners all saw, again, this considerable improvement in those targeted areas. So we believe this can be useful for people. However, we know that not everyone will have access to a practitioner. We also know that people with dementia, and many of them are themselves very resourceful and try to find strategies that work. So alongside this, we've been working on co-producing self-management resources, drawing on those principles of that enabling intervention, great cognitive rehabilitation. So it's going to be called My Life, My Goals. Currently in development, will be hosted by Alzheimer's Society. Here you can see an early version of what it might look like. And we've worked with a fantastic group of people with dementia, some of whom you can see here on one of our Zoom calls as we've worked on this together during the pandemic. And so we hope that this will be accessible and useful for a wide range of people with dementia. Very much in the forefront of this is giving a message of hope. Our group felt that it was very important. They feel that often at the time of diagnosis, they hear a great deal of negative information, and they feel that while it is never welcome to receive a diagnosis of dementia, it is also still possible to have some hope that you can live well with the condition. And this is the aim of this work, is to support people in living well with the condition. So coming back to the social context then, again, there's a great deal we can do to also create a social context that enables people to live well. We, again, in Ideal, we're fortunate enough to be able to work with some fantastic groups of people with dementia who are members of dementia engagement and empowerment groups around the UK. And our artists, Ian Beasley, Ian McMillan and Tony Husband, worked with them to understand what helps them to live well and find ways of expressing that. And so I've listed here some of the themes that those groups wanted to work on. They wanted to raise public awareness of these areas. So they felt that being able to get out and about was very important, enjoying friendship and social contact, and feeling included. For example, if you go to an arts venue such as cinema or a concert. In terms of generally being out and about, they felt it was important to make signs clear so that it's easy to find your way around, and to make everyday technology easier to use, things like ATMs, automated checkouts, ticket machines, and parking payment machines. And I'm sure that all of us at times struggle with new versions of those. And for people with dementia, of course, it's a massive challenge. So we could devote some attention to making those user-friendly. Then coming back to services, having an integrated social care system that makes it easy to access the support you need. People find it very confusing to navigate the options or to understand what's available to them and what would be helpful. And generally bringing dementia into the open so that people are aware of it. And so we can start to build on this dementia-friendly initiative. And in our Ideal sample, it was very interesting to see that when we asked the carers whether they thought they lived in a dementia-friendly community, about half of them thought they did, which is fantastic, but equally the other half didn't think they did. And so we do have more work to do to bring dementia out into the open, to make people aware of it, and to make changes that support inclusion. And of course, the best rationale for that is the fact that if it's going to work and be accessible and friendly for people with dementia, it's going to work for everyone else as well. It's be better for all of us. And for people with dementia, it's very important, many of them find very important, to have peer support and to stand together as a community of people living with dementia who can help to advocate for change and improvement. And I just wanted to share with you finally the results of this particular arts-based work, which the groups of people with dementia developed banners showing their experiences and highlighting these issues that they wanted to put forward and advocate for. And this was being turned into an exhibition. It was launched in the UK in December 2019, and a book a few months later. The exhibition has been on hold because of COVID, but it's now touring again in the UK. And the idea is to offer a message of hope and change that encourages all of us to think what can be done and to build on what we know about what could be done to make it easier to live with dementia and to support people to live well with the condition. So thank you very much for listening, and I would just like to end by acknowledging all of the people involved in this huge area of teamwork. So the research participants in the IDEAL and GREAT programs, the IDEAL and INCLUDE and GREAT research teams, the Always group and the IDEAL program advisory group, our funders, Alzheimer's Society, ESRC, and the National Institute for Health Research. And for further information, please feel free to have a look at one of these websites. Our IDEAL project website and the Unfurlings website will be particularly relevant. Follow us on Twitter, and if you would like to get in touch, there is an email address here where your email would be picked up. So thank you again for your attention, and thank you again for inviting me to be part of this very important initiative about prevention and intervention. And I hope that this evidence will be of some value to you. Thank you.
Thank you so much, Professor Clare, and welcome. I'm very delighted to see you. I'd like to just give a little bit of context to the audience. We have Professor Clare, who will take questions directly from her presentation. We also have Dr. Charlwood, who will be available for additional information. And finally, we have Dr. Yutsu Wu, who has already presented and will come in after Professor Clare to answer questions specifically directed to her presentation. So thank you, Dr. Clare. I have 5 questions that I would like to put to you, coming from the audience. The first question is, in your project, the follow-up questionnaires were administered to patients and carers. How do the results of these 2 groups compare?
I'm not quite sure which project you're referring to. We usually...
Okay, we'll come back.
So, are we talking about the IDEAL or the INCLUDE? I think the GREAT one, the cognitive rehab, would have been obvious because I showed the carers data there.
I'm sorry, I don't know. I'm relaying questions from the audience, so we'll come back to it. Okay,
well, just to say, I mean, in IDEAL we have information from people with dementia. We have carers acting as informants about those people with dementia and also talking about their own experiences. And obviously, we know that carers will tend to rate things slightly differently to people with dementia when they're acting as informants or proxies when we use the same measure. In fact, Yutsu Wu had led on a paper where we looked at this, and we established that with regard to quality of life. Yes, they do rate differently, and so when we're looking at individual perceptions of quality of life, we need to take those coming from the person with dementia because the carer is seeing it differently. But when we're looking at associations with other factors, that we do see a fairly similar pattern. So it is legitimate to use one or the other. If we don't have ratings, we can't get ratings directly from the people with dementia. It is reasonable to use ratings from carers, although I don't think it's probably advisable to mix them up in one analysis. So that would be a general comment.
Thank you so much. I think that's very clear. The second question is it possible to influence the psychological factors that affect the trajectory of living well with dementia at older ages or in patients already suffering from dementia?
It is in some cases, and obviously there are some psychological factors that we wouldn't be expecting to change, like people's personality traits. But on the other hand, things like depression, which is very crucial, can be treated, and also loneliness is another one that we could perhaps do something about very readily if we have the right context. Optimism is another interesting one, because we might influence that by how we talk to people about the condition and what we say when they're diagnosed. People with dementia tell us they get very negative messages at diagnosis, but they are, in their own experience, they are still able to enjoy some aspects of their life and to have good times in their life with dementia. And so they want a message of hope alongside those tough messages, which, you know, are inevitable with a dementia diagnosis. So I think there is a lot we can do to influence the psychological factors and help people in their adjustment to living with the condition.
Thank you so much. The next question is, how has the use or lack of access to telemedicine during COVID pandemic impacted care in the cohort that you follow with IDEAL?
Well, we do know that, you know, of course, right at the beginning, many services closed down, and many informal networks also closed down. And that had an impact on people, of course, in terms of isolation for the person and burden and worry for carers. However, in general healthcare, people were not too, we didn't see a very high proportion of people saying their general healthcare was badly affected. Now, what we did learn is that where it was possible for those services to keep in touch, even minimally, with the occasional phone call, that was really valued. But of course, many services are in the voluntary sector and not funded, and have had to close because they couldn't keep staff in post during that time. So yes, it has been very difficult for people. However, you know, many people have been able to adapt quite well to using online methods. So they're much more likely now to have telephone or online contact with their GP, for example, their general practitioner. And what we do have to worry about is those people that don't go online and don't use don't access information that way. We have to remember that not everybody is doing that, and think about other routes to that.
Thank you, that's very clear. And finally, the question from the floor is, what is the relationship between caregiver burden and perceptions of living well? Did you find an inverse relationship in some cases? And is this relationship different based on variables such as gender?
Okay, so I think that some of that I can comment on directly. Others, I think, we didn't, just to say, we didn't use a measure of carer burden. So we have looked at stress for carers, and also some aspects like role captivity, and we have positive aspects of caregiving and caregiving competence as well. So we do have, so, I mean, I'm going to have to refresh my memory as well personally on the exact details. So I'd really like to direct you to our website, because the publications are there which talk about this in detail. And yes, we do show that there are some of those factors for the caregiver do affect the well-being of the person with dementia, of course, and vice versa. So we're progressing some of those dyadic analyses to look at those actor-partner effects. For example, we see that depression in one member of the dyad will affect the well-being of the other. So we can trace some of those effects, and it is very important. We do need to think about where there is a caregiver involved, which is the case for many people, but not, of course, everyone. Then we do need to think about that caregiving dyad and understand that if we address some of the difficulties for one member, it should be helpful for the other as well. And we will be working more in that area of dyadic analysis in the forthcoming work.
Thank you, that's wonderful. Now, I noticed that Dr. Charlwood has sent a great deal of information to us, and I would like to just clarify for the audience that Dr. Charlwood is working together with Professor Clare on the public dissemination of the work, and so there's several links to download. One of them is relevant to COVID, so please do take a look. Another is a direct response to some of the questions that I posed to Professor Clare. So all that information will be in those papers, thanks to Dr. Charlwood. let me introduce Dr. Charwood more formally. Dr. Catherine Charwood's literature doctorate was interdisciplinary with psychology, looking at memory within poetry. She has published on a variety of literary topics, including aging in the novels of Kuzo Ishiguro. A co-host of LitSci Pod, the Literature and Science podcast, Catherine is committed to finding new ways for research to reach a wider public. She is translation manager and impact manager for the IDEAL project, and she seeks to share the many findings of this important study with the varied stakeholder audiences who stand to benefit. As a former teacher, Catherine is particularly interested in bringing research impact to school students and teachers, and we're absolutely delighted that we have Catherine with us. It's extremely helpful. Catherine, did you want to chime in and say something to us today?
Just very briefly, that was a mammoth introduction for the small amount I'm planning to say, but thank you. Yeah, just so there are lots of links in the chat, and I will add a few more, so please feel free to look at whatever interests you. Just on that last question around carer burden, as Professor Clare was saying, we're seeing some really interesting findings around how the modulating effect of each partner on the other. And so one of the links I've put in the chat is how we've been relating these to the recent Oscar-winning film, The Father, which I don't know if it's out where you are, but if you have seen it, you might wish to look at those. And just to add to what Professor Clare was saying, I think one of the interesting findings is the view of the quality of that relationship from either the carer or the person with dementia. If you view your relationship between the two of you as having a poorer quality, that indeed does affect well-being. That was all.
Thank you, that's very helpful. We're trying to develop some translation in the meeting, and this is the ideal session to do that. And your work at Exeter is absolutely exemplary for doing that. And I'm very pleased that you've been able to give us such a pithy summary and concise summary. I wonder if at the present time you would be happy if I took some questions for Dr. Wu. By way of introduction, Dr. Wu worked with Professor Clare at Exeter, and we heard earlier from Dr. Wu some specific examples of her work at Exeter in the IDEAL project, and also I think possibly also in Bangor. So I've got two questions for Dr. Wu, and she's with us. I'm going to direct them to her and ask her to respond directly. The first question for Dr. Wu is the following. How do you envisage collaborations between architects, urban planners, and mental health researchers and professionals in the development of environments that support well-being? Dr. Wu?
Hello, thank you for inviting me to this conference. So regarding the questions about how different disciplines can collaborate to investigate the impact of the environment on healthy aging, I think different disciplines of researchers have their own focus, have their own interests. In more medical public health research, we tend to analyze the data we have. We tend to do either quantitative or qualitative interview to understand the relationship between environmental factors and health outcomes, but how these can be translated to the practice, whether we can have a more experimental research type and incorporate the urban design researchers, architectures to design a more like clinical trial studies that would be from a more health researchers' perspective to more practical sides. For urban designs or architecture researchers, I think it would be useful to incorporate the elements of healthy aging ideas to consider what would be useful for older populations to take their needs into account when they decide, when they try to plan the urban settings. And there are several opportunities for that. So there are some natural experiments studies try to observe the change of environments and see how that impact people. So I think from two directions can meet in the middle and to provide more robust evidence and to identify the practical approaches to bring these healthy aging and age-friendly environments forward.
Thank you. That's very clear. One more question for you from the floor. Have you seen any examples of cities or specific public spaces that you think demonstrate best practices for healthy environmental design?
I think the healthy environment designs can be a quite broad idea. So we most of these environmental design needs to consider whether we can encourage activity of individuals, physical activities, social interactions. It needs to consider elements of safety, sustainability, environmental friendly, and so on. One of the example I think is quite interesting is the Cambridge bus link. So in the Cambridge city centre used to be lots of problems about traffic jams. It's a very old city centre and lots of traffic needs to pass through there. So how to link the city centre and outside research areas such as the Edinburgh Hospital. It used to be a very big issue, and the bus link development tried to build a fast pathways for bus to link the city center train stations and medical centers. That would be, I think that's a very novel idea, and there's a body of research try to look at how that improve the behaviors of individuals, how they use their traffics, and how that promotes people use public transport. So I think that's one of the interesting examples in terms of healthy environment design.
Thank you so much. That's a wonderful answer, and I'm sure we'll go and look up Cambridge bus stop immediately. So at this point, I'm going to pass back to our chairperson in Hong Kong, Dr. Kateri, who also coincidentally had worked with Professor Clare in her previous life before coming to Hong Kong. So I believe Teresa has a question directly for Professor Clare. Go ahead, Teresa, and take over.
Professor Clare, we are delighted to hear you in this conference, and your career, your work is very inspiring and acknowledged in the whole world. We followed your work in cognitive rehabilitation from very old years, and with patients with dementia. And I would like to hear a little bit more, if you could elaborate more on the great cognitive rehabilitation program and on the how it was designed, how it was before the pandemic, and how if modifications were needed in the context of the pandemic. And I'm sure everybody wants to hear about this. Thank you so much for being with us.
Oh, I see. So, so the Great Cognitive Rehabilitation Intervention is an individual intervention, personalized, which takes place in people's own homes. So the practitioner will understand where people are having difficulties with activities they want to do or need to do or would like to manage better. So they'll be able to look at all of the stages in that activity and pinpoint where the problems are coming. So for example, it could be someone is too anxious to start doing whatever they need to do. Let's say they've got to cook a meal, they're too anxious to start because they think they'll make a mistake, or they get muddled up at a certain step, or put something back in the wrong place and can't find it. Or perhaps they do get their meal into the oven, but then they forget to take it out and it burns. And we did have a participant who was going to have his gas supply cut off by social services because of the risk of burning the food leading to house fire. So we would work with people on those everyday issues, and the practitioner would find strategies to help manage those situations. And then we will evaluate how well that works. So that's a general format. Now, it's been done by us in the format of a research project or an implementation research project. So when COVID hit, all of that had to stop. The NHS services were not going out to work with people in their own homes. And in fact, they weren't able to do it. We did discuss whether they could do it remotely in some way with people who could manage that, but they weren't able to because the staff themselves were not, were not working in the usual way. Some of them were furloughed and so forth. So in fact, we haven't adapted it to pandemic conditions. We rather restarted now. But in fact, the project itself is coming to an end. So we're now working with those services that have been implementing it. We have developed a model for wider implementation. So guidance for services, and also we have e-learning for practitioners. That's going to be on our National Health Service e-learning hub, so practitioners can gain the skills. And so from those two directions, really encouraging services to take it up and practitioners to gain skills, we hope to see that developing further. So our research work was to, as I say, to develop this model for further implementation. So I think there'll be further collaborations developing. One thing we would like to do, but it would be a new project really, would be to adapt that for remote, for telemedicine kind of approaches, but we haven't done that yet. So the implementation model has been centered around an average of 6 home visits from the practitioner to address, in particular issue, a goal that the person, or 1 or 2 goals that the person wants to work on.
Can I just very briefly add one thing about GREAT, just because I was very privileged to be able to join a focus group on this with the people with dementia and carers speaking. And it goes back to that point about design that that Yusu Wu was answering, that one of the things that perhaps if you don't have dementia, we hadn't considered was the idea that with a downloadable paper version of the materials, that they wanted them to be one-sided so they could stick them up and actually kind of consult them and have that visual reminder on the wall. So I think it's just important to raise that idea of quite simple aspects of design that perhaps if you're not living with the condition, you could easily overlook, and hence the importance of involving people with the condition at all stages of the research. So yes, I just wanted to add that.
No, it's very true that, I mean, in terms of the rehabilitation itself, and it's quite timely now because people are asking for rehabilitation from COVID because people feel their skills have declined and they've been isolated. It's really important that we think about people's environment. So we can give people strategies for learning or relearning, or sort of internal strategies, if you like, that they can take on, so mnemonic strategies or whatever, but we can also look at compensatory strategies. So as Kathy mentioned, if you have the instructions in front of you on a list on the wall, you can follow them. If they're in your head, you might not do them in the right order, you might forget them. Of course, all of us can be subject to that, but it's much more important when you have cognitive impairment. But also we can think about designing the internal environment of the home. So we often talk to people about having a workstation where all the things they need for a particular activity are gathered together, or assembling everything they need before they start and putting it in one place in the right order. Or a really neat small example was someone who was having trouble finding the light switch, putting a large yellow piece of card around the light switch made it prominent, so making the important things prominent, so forth. So there's a lot we can do in an internal design of the home environment too. And also, just finally to say, a lot of our people with dementia now say they're using aids like Alexa, and these kinds of things help support their activities when memory is not working so well.
And GREAT is going to be incredibly important, because just yesterday a group of charities, including Alzheimer's Society, called upon the government for a rehabilitation strategy, a national one, across not just conditions like dementia, but also stroke, podiatry conditions, because one of the things that is becoming clear is that post-pandemic, and we're not there yet, there's going to be a need for a coordinated national rehabilitation strategy.
And as we showed, functional ability is really central. and directly related to people's ability to live well. And the more we can support, and supporting functional ability isn't the same thing as improving cognition. So the more we can support people's ability to function and feel they're independent and in control or managing as they would like to, and it allows them to engage in activities. And the wider benefits, what we hear from people in their feedback is it makes them feel more confident. They feel more, they feel that it's helped them with their adjustment to living with dementia by thinking through these strategies and approaches, and often the support the practitioner gives can translate into improved problem solving. So when the next problem comes along, they have a framework for tackling it. And you know, as we see from IDEAL, these things are directly related to ability to live well.
Thank you very much. I will pass now to Professor Weeks for his final considerations. We are approaching the time of the end of our event.
Thank you so much, Teresa. And I wish to thank again Professor Clare and also Dr. Charlwood, because this is a really great way to complete the entire conference, showing how impact is critical to our work. And congratulate Professor Clare on the incredible job that she's done to make it clear to the community and to us in the Greater Bay Area, the relevance of the work of IDEAL. So thank you once again, and we very much appreciate your coming in and telling us about your resources, and we will ensure that the link sent by Dr. Charlwood will be uploaded to the conference website, and we will also make sure that curate all of the relevant information for attendees in the post-conference phase to watch videos, download website information, and also hopefully receive answers to questions that we were regrettably unable to answer due to time constraints. It's now after 6 p.m. in Hong Kong, and the team has been exemplary in their ability to coordinate a virtual meeting across every time zone on the planet. We've been awake since very early in the morning, and this is the end of a bright green event, which we would say is completely carbon neutral. And we must say, I think, has won us some applause in the ability to create a space for celebrating what was to be a face-to-face event without any implications for the environment. And Dr. Carteri would like me to finish the event with hope. I'm not sure what she means by that. H-O-P-E. Would you like to elaborate, Teresa?
I'm talking about Professor Clare talk, her program, and the hope she has mentioned in her lecture.
I see. I'm sorry, I missed that link. Very, very good. And I would encourage further discussion amongst you all, and hope that will be the result of the event. And I wish you well and good night in Hong Kong, and look forward to. We have another quick message from Dr. Charlwood. There is hope to be had as people with dementia want us to know. So there's a YouTube link as well. So much to see. I certainly won't be taking a nap. Continue to read for the rest of the day and look forward to that very much. So again, thank you all, and thanks to Murphy and his team. And we would like to wish you all the very best and with your future work, and look forward to keeping on track with the results of the IDEAL and other projects at Newcastle and Manchester universities that we are more aware of today. Thank you and good evening.